Welcome to the Aural Apothecary podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Guests share their career-defining drug, song and book, and also share their joyful patient stories. Welcome to the Aural Apothecary podcast. My name is Jamie Hayes. For this episode, we're joined by Professor Tony Avery. Tony is the National Clinical Director for Prescribing for NHS England. He is also a GP in Nottingham and Professor of Primary Healthcare at the University of Nottingham. We will welcome Tony in a moment as he shares a drug for our formulary, his career anthem, and recommends a book for the Aural Apothecary Library. Spoiler alert, after over 60 episodes, it's a first in class for Tony and his career anthem. More on that later. Our micro discussion this week will be informed by the annual report of the Chief Medical Officer for England, Professor Chris Whitty, I think, Health in an Ageing Society. But first, let me welcome my two fellow apothecaries. STC's in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening.
Evening.
What have you been up to?
So, I was going to report on the demise of an old friend, not in that way, but Codeine Linctus went to POM earlier this week.
Prescription-only medicine now, yeah.
Yeah, so it's gone from a P to a POM, and I mean, I must admit, I thought it already had, because I haven't worked in community for a while, but it's well overdue. But it just did make me think, because it's sort of one of the last bastions of the old days of community pharmacy when we were giving up pretty much anything. So it probably won't be missed, but it did make me hark back with a bit of nostalgia. And then the other thing I was going to mention.
Well, hang on a minute, just to say on that, circa 1984-85, when I used to work in my dad's community pharmacy in Milford Haven. Even then, he'd keep the Codeine Linctus would be under the counter, and he'd be very strict about who was allowed to have it.
Well, I was going to say, I think any pharmacist over about 40 has probably got a Codeine Linctus story, haven't they?
Well, do you remember my Codeine Linctus story from Series 1?
Oh, God, of course you've got one. No, go on.
Series 1, I was a student in a pharmacy in Bridgend. Somebody came in for Codeine Linctus. The pharmacist did a brilliant job of diverting them and saying, oh, I think we're out of stock, actually. And I, little Keno in the background, said, no, we've got loads of it back here.
I do remember that.
I remember you saying it now, yeah?
Yeah. Lloyd's Pharmacy, Adair Street, Bridgend. You're welcome.
Well, talking of first series, we just realised, didn't we, when we were chatting before we came on air, that it's about 3 years since our first episode aired. So that's another milestone. The other thing I was going to mention, Jamie, I don't know if you were going to mention this, was our visit to Big Moose Cafe. Don't think we've mentioned that on the pod yet, have we?
We haven't. Go for it.
No. So it was brilliant. So the profits from our live show, we took down to
all the proceeds. All the proceeds.
Yes, proceeds.
All the proceeds.
In case a taxman's listening, and we gave it all to Big Moose charity. So it's a local Cardiff-based mental health charity. They offer counselling and support to people who refer themselves into it, and they've also got a great little cafe down just off Queen Street in Cardiff. But it's great, wasn't it, Jamie? And we had a good chat with them, and actually in that chat started to think about maybe more we could do with them in partnership in terms of supporting some of their work and utilising our sort of networks and stuff. So it was good. And
we met Alex, who runs their finance side of things, but she mentioned that their Chief Executive Officer, Jeff, has Parkinson's disease.
Yeah.
Was currently in base camp in Everest, and so when he returns, we will discuss with them possibly putting on another show.
Yeah.
Here's a link to mental health. I was going to bring this up. I'm a lover of podcasts, so one for the listener. If you haven't heard it, it's a podcast I've mentioned before. Her name is Liz Tucker. She was an ex-BBC reporter, and she does a podcast called What Your GP Doesn't Tell You. And last week, I think it was, she had Dr. Mark Horowitz, who was talking about, very candidly, he talks himself about how many mental health drugs he was on. He comes from Australia. He's actually training to become a psychiatrist and was a researcher. And he talks very candidly about, let's say, use and overuse and perhaps underestimation of antidepressants in particular, and then how to try and get people off antidepressants and just how difficult that is. And so he's got a new book with a pharmacist called David Taylor from the Maudsley. And so it's a really good listen. Honestly, it's a really, really good listen.
I listened on your recommendation and it is superb. It's essential listening, I would suggest.
He'd be a great guest, wouldn't he, on the Aural Apothecary?
Yeah, essential listening. Okay.
And on a lighter note, I went to Twickenham for the rugby, and All I'm going to say is self-service Guinness. It's the future.
I've seen that.
Obviously, we don't mention the rugby while Wales are going through transition years.
No. It's all about 2027.
Indeed. Okay. Look, I was up in Liverpool here in the week at the Behavioural Science and Public Health Network Conference in Liverpool. Another opportunity to catch up with Sir Michael Marmot. Had another conversation with him, trying to influence him to come on the podcast. So we'll follow that up with an email. He was brilliant and inspiring as ever, but it was Wales's very own Ashley Gould, who is the Programme Director at the Behavioural Science Unit at Public Health Wales. He was brilliant too. Ashley delivered his talk about the behavioural dividend you get when we manage to deploy behavioural science well and effectively.
Oh, I like that.
But sadly, this is the point. There were about 200 behavioural scientists in the room, and we will come on to this with our guest in a moment, I hope. 200 behavioural scientists in the room and health psychologists. I asked for a show of hands in one of the workshops I was in where there was a third of the people in there, and only 2 or 3 put their hand up to say they were actively working on medicines-related issues, because they're working on other public health. They're working on diet, schools, and other key public health areas. So we need to get more of these people on our medicines agenda.
Well, it was a small world, but I'd been speaking to Ashley over the last couple of weeks about us in CTM doing something around behavioural change and perhaps setting up a mini unit that's linked to his team. And one of the things he mentioned to me was that they're looking at behavioural change in diabetes drugs, and one of the issues there is almost a reluctance of some clinicians to prescribe and use the newer drugs because they're not familiar with them. So I thought that was me paraphrasing what he said, and that might not be exactly what he said, but it's about how some of the newer regimes are actually regimens are so different from what people have been taught in the past that, confidence might be an issue.
It's true.
Look, before we move on, it's worth mentioning that by the time this episode is out, we will only be 1 week away from our next live show in Bordeaux at the 28th Congress of the European Association of Hospital Pharmacists. It's more of a back to Bordeaux for STC and myself. Looking forward to that.
Yeah. I think we better get our guest on. The people might be tuning out. Actually,
let's move
on this week.
Shut up. Let's move on. It's our great pleasure to welcome Professor Tony Avery. Tony is passionate about ensuring the safe, effective and appropriate use of medicines and has worked in partnership with healthcare professionals and patients for over 30 years, driving forward research and policy development in prescribing and patient safety. He's led a number of major studies investigating the frequency, nature and causes of prescribing safety problems in the NHS. He has also developed effective methods for tackling hazardous prescribing, most notably the pharmacist-led pincer intervention, which has been rolled out nationally to general practices in England. Tony was awarded an OBE in the 2022 New Year's Honours List. Welcome to the podcast, Tony.
Thank you very much. Delighted to be with you.
It's been a while. What's top of your in tray at the moment, Tony?
There's quite a lot of things in my in tray. One of the things I'm particularly trying to focus on is on tackling chronic pain and getting better approaches to that. Trying to avoid over-prescribing, over-investigation. But it's a real challenge because, pain is real, but we've discovered, particularly for chronic primary pain, that medication doesn't really help a great deal, and at higher doses can cause a lot of problems and more problems than they solve. But I also know that as a GP, when I see someone with pain, I'm looking for an underlying cause. That often means that investigations, sometimes referrals, and I'm aware certainly from the past that sometimes this can actually go on over the course of several years with the patient receiving increasing range and doses of medicines over that time, and then it can be very difficult to pull back on it. So I think we need a radically different approach, and that radically different approach is starting to happen in places with offering biopsychosocial approaches early with the aim of trying to avoid harmful over-prescribing and over-investigation.
So you work with STC on a regular basis, so we'll freeze him out for a moment. Describe to our listener, how do you keep those 3 aspects of your role going, the GP, the national and the academic? How does it all work, Tony?
It works very well, surprisingly. I think one of the advantages of being an academic is that it does give you a bit of freedom across the course of the week in terms of how you manage your diary. So I try to do my NHS England work roughly on certain days and certain times, but it means I've got flexibility across the week apart from when I'm doing my clinical, which is the Thursday afternoon and evening. So the academic really helps to inform the national clinical director role, just in terms of the evidence side of things, but the clinical side is just absolutely crucial. It just bring it in so much of the time to my work. And to be honest, I feel that in terms of my national clinical director role, then at least half of what I bring is as a practicing clinician rather than having any particular expertise in medicines. So as I say, it works really well, and each feeds off each other, each contributes to each other.
What would be the successes you would reel off, Tony, that we've made or that you've made, not you personally, but the collective have made in the last few years?
Well, I think we are making great strides, to be honest. I mean, I think the National Prescribing Review, I think everyone acknowledges it's a really, really good report, and the recommendations for that, as a call to action, and the creation of the role that I'm in was to provide clinical leadership for addressing those recommendations, and we're making really good progress on a lot of them. I mean, one of them is just the cultural side of things, and there's just real interest. I've found numerous invites to meetings of all sorts of different professions and patients and public groups as well. There's almost a zeitgeist around this in terms of recognition that we've perhaps just gone a little bit too far in terms of over medicalizing and over prescribing, while recognizing that medicine, of course, do fantastic amount of good for lots of people. But that thing where people are on, medicines for every single condition they have, but you add it all up and it becomes, a challenge, but a challenge for patients even to take those medicines, but also a challenge because of the way in which those medicines don't necessarily work well together and cause patients problems. So there's been that aspect, but then there's been specific things. So the AHSM polypharmacy program has been fantastic. I've often said that if it was not created, we would have had to invented it, and indeed NHS England has been supporting that financially because we're so impressed with it. But setting up the sort of polypharmacy comparators through the NHS BSA, and then the action learning sets for healthcare professionals. Just been transformatory really for many GPs and pharmacists who've been on that, and it's been fantastic having input from geriatricians in particular, because I think the real challenge people have, like myself and many pharmacists working primary care, is the confidence, because there's no roadmap with a lot of this. There's no absolute right answer to what you do in this particular patient. You can't go up and look up a protocol which tells you what exactly to do in this particular patient, and therefore it can feel like going a bit off piste, and therefore having people who've like geriatricians who live and breathe this to help give the confidence for some of the decisions that, along with patients, that we need to be making to help them get on better with their medicines, I think is really important.
So that sounds fantastic, and it's sort of music. You'll know it'll be music to our ears in terms of this podcast and what we talk about. But how, there's not an easy answer to this, but how do you're trying to influence ingrained behaviour across a number of professions. So what techniques have you used to do that?
Well, it's interesting. It's thinking about what techniques I might have used with other people. I'm just very much aware myself of just how much even more cautious and judicious I am in terms of my prescribing. And I think one of the things is I often feel is there's the evidence out there, but then as a health professional is actually believing the evidence and then incorporate it into your work. So there's an example last week of the standard thing of a patient coming along, they're on antidepressants, they feel they've helped them a bit, but they feel that perhaps an increased dose might be helpful. Well, in the past, I and probably a lot of GPs will say, okay, we'll notch it up a bit. But then when you've seen the systematic review suggesting actually it doesn't really add much and it just increases the risk of side effects, then it puts you in a much stronger position to be saying, look, actually, that's perhaps not a good idea. Let's stick with the dose that you're on. Let's see if we can get you some more help on the psychological side of things, for example. So I think that's one of the things, is perhaps trying to get that out there. It's the same with chronic pain as well. Until you actually believe the evidence, then your behavior doesn't necessarily change when you actually really get it that these medicines don't actually work for chronic pain, particularly chronic primary pain, or don't make a lot of difference. That really, I think, does make that difference in not prescribing or trying to avoid prescribing.
And just for the listener, a lot of the stuff that Tony's talking about is Claire Howard, who, as you know, is the 4th or maybe the 5th Aural Apothecary and has featured on this podcast a lot. And I do a lot of that work with her and Zoe and Jonathan Underhill and others. And as Tony, you said, confidence is key. And my 3 C's actually, when trying to encourage people to think about when they're doing medication reviews, is to think about you need curiosity, then you need confidence, and you need courage. And you need all 3 of those actually to be able to do it. And it's okay if you're a geriatrician, you've got all of those in spades, but they're like the SAS, aren't they? Whereas we need a cadre of troops underneath that are comfortable to do some of the lower level stuff, or even the mediate and intermediate level, so that the geriatricians can then do their stuff when patients, perhaps, end up in a hospital or a community hospital. And confidence breeds confidence, just doesn't it? And that's the message that we're trying to get across. But when it comes to how do you and others, not just you personally, but how does the world try to prove that we've got good evidence that doing it actually is beneficial for patients? That's quite tricky, isn't it?
Yeah, it is. Although there is evidence there is evidence out there, and I think the key thing as well is going with the patient. This being something that we are doing in partnership with patients, and it makes it a lot easier when you talk through the medicines and talk through what the priorities for patients. If they're bringing up, do I still need to be on this antidepressant? Do I still need to be on this? It's giving you the sort of opening that, okay, that might be where we go to today in terms of the medicines that we might talk about. It's not appropriate to stop all medicines, of course, but where it is appropriate to do that, and that medicine may be causing more harm than good.
But do we need to worry that we haven't got good, Cochrane level evidence to say that doing good structured medication reviews with the patient and taking their views on board? And I'm asking this to you, I have a view on this, but I'm asking you, do we need to worry about that?
Well, we do have good evidence. It depends on, if you take sort of, large systematic reviews, and there's just been a review of reviews done, which overall I have a positive take on, then often you'll find with these things that there's no definite proof for this or no definite proof for that, and I wouldn't want to be cherry picking, but actually when you do sort of dig a bit deeper and look at those studies or systematic reviews that have made a difference, you perhaps see sort of characteristics in them, in terms of the amount of time that you're spending, about it being patient-centered, about having healthcare professionals who, have, particularly pharmacists, who've got that knowledge and experience,
and time.
And time. Yeah. Time is very, very important. And the ability to also follow up on the, because it's certainly in my experience, it's not a one-off thing. So I think, we've got some good evidence out there. It's not at the level of statins and prevention of coronary heart disease, but also it's just the right thing to do. If you're a person who's on 10, 15, 20 medicines, you're an older person who may be frail and struggling with your medicines, you may have a carer who's helping with your medicines, it just feels like the minimum we could be doing is to have a sort of decent review with the patient and or their carer at least once a year, to just go over those medicines and check that they're working for them or how they're working for them, and to see whether actually we need to tweak them, whether some of them are not doing the job that we want them to be doing and maybe causing more harm than good.
Okay, so just to add to that then, Tony, a piece of work I'm involved in at the moment is I visited a community pharmacy last week and started listening to the stories that the patients were telling me. We want to go in and take photos of medicines in patients' houses. So we don't want them to tidy up. We want to go in and see how they use medicines and how they manage their supply. And one of the stories I had straight away was a gentleman. He was in his mid-70s, and he just shared with me straight away that his medicines are downstairs in the kitchen cupboard. There's lots of other things in the cupboard. And as he was telling me the story, he then, oh no, but my apixaban and my simvastatin, which I take at night, they're upstairs in a little box that my dad made for me when I was a child. And so I said, oh, that's the photo we need. But I think that we put a lot of effort into getting the diagnosis right, and we get a lot of effort into getting the therapeutic decision correct. But then actually we don't have much of a clue of how patients behave with their medicines behind their front doors, do we?
No, and I would just love for us to be able to do more than this. You're probably aware of the work of Deb Gompertz and the Show Me Your Medicines, Please, and encouraging health professionals and care professionals to ask to see people's medicines. In part, that can be in terms of seeing if there's oversupply going on and they've got cupboards full of things, so we can have an honest conversation about this and get them sorted. But also, as you say, to see how people manage them. I mean, many of us perhaps have our own experience, but have relatives. Certainly, I've got a relative where it just astounds me in terms of how it all works, and it is really complicated.
Yeah. Oh,
that's the point.
Yeah.
I was speaking to someone today who was sort of saying, I just don't know how I would manage to be taking 10 medicines a day.
I think that's the bit that I get very agitated about when I get on my soapbox about single organologists. And I'm sorry to go on about it, but when I was at the Geriatric Society,
no, you're not.
No, and we're actually having a cardiologist on later in this series. Okay, so I'm very happy to take questions. But my point being is that if people are devoid of living in the real world, then I don't think they're doing themselves as they're not. I don't think that as health professionals they're doing their job as well as they can do if they're working in an ideal world rather than a real world.
But equally, I mean, it's fair enough for a cardiologist to suggest a bunch of medicines a person's taking. I think it can then be perhaps for us to be tweaking if it's a very difficult regimen. I use the correct word. If it's for us to tweak that so that see if we can make sure it's a twice daily and try help with particularly with the help with pharmacists, try to make sure that people are not so obsessed with when people are on lots of medicines, it's like this one's got to be before food and this one's got to be a little bit after food and this one's got to be at 11 o'clock in the morning, and it becomes so incredibly complicated. So I think it's to some extent for us in primary care to be trying to manage the whole thing.
But Tony, if we go back to the start about courage and confidence, how many people have got courage and confidence even when they know that person is really struggling and is needing to go to the toilet 12 times a day and has given up going out because of the diuretics? How many people have got confidence and courage to say that it's okay not to take those, or as long as we've understood what the risks are if we don't take them as often, because we fear that the specialist has said, it wasn't a suggestion, it was a mandate.
Yeah, I'd hope that most of us, certainly with that particular example, I'd hope that most of us would have that confidence.
That's not what we hear when we have people on the ALS every month.
Yeah,
we don't hear that at all. People fear that. And that's my point about confidence and courage, and why sometimes I get irate about people living in an ideal. We don't live in an ideal world. We live in a real world. And you've just said how, Claire always talks about, her dad and how difficult it was in relation to all the medicines he had to take. And it's this belief that if we take them all, that, we're going to live forever. And that's blatantly not true.
There's some more of that real world for you. Look, I'm going to finish my point. People shared medication with family members, 87%. Friends only, 26%. Neighbours, 63%. Friends and acquaintances, 7%. And colleagues, 8%. So all that medicine that we're giving out is we have no idea what's going on with it, do we?
What I'd be interested in is how much of that is a bad thing, because we cringe at it and think that's terrible. Has that saved the healthcare any any
And
appointments.
to be
or
fair to them,
any
they
stuff.
go
They make
go
their
on
own
to-
decisions that suit them, and actually that's a good thing for them.
They go on to discuss that. They do.
But
Do
also,
they?
I find it quite helpful when when patients can be honest and they'll come in and actually say, I tried this that my wife was taking and I found it helpful, and it may well be the right thing for them.
Yeah.
I bet we've all done it.
Well, it makes me think about once when somebody asked me, is it okay because the patient's wife had decided that she'd taken his sildenafil accidentally, and actually she found it quite helpful, and could she have it on prescription?
Between 3 and 40% reported experience side effects after borrowing prescription medication.
Maybe not. Maybe not. I'm not advocating it, by the way. What I was really interested in it goes right back to that behavioural change thing, isn't it? Is what you're trying to do with your strategic work, isn't it, Tony? Is influence prescribing patterns, across the whole of the country. And I think Steve's alluded to how he sees that not necessarily happening, but it's really difficult. So I was just interested in, is there any particular success story in terms of where you've influenced something across the whole country that you're really pleased with how it went?
Well, I think some of the work that's being done with the polypharmacy program and taking account of evidence, particularly from colleagues in Leeds and Bradford, on communication with patients around that, and sending patients information about the sort of questions they might want to bring up or consider prior to a medication review. We're getting good feedback on that, just in terms of how useful patients are finding it and how useful it is for healthcare professionals in terms of I suppose patients being more activated prior to a structured medication review conversation.
I think you're right, Tony. And we've had Graham Presswich on, and that's obviously Graham well, and Me and My Medicines, and he was so clear in that if you support the patient to begin with and then trust them, it's going to work well, in a co-working kind of way. So yeah, letting them know what they can talk to us about when they come, and being prepared. Because I prepare when I do a medication review, so I'd expect them and would want them to prepare themselves. But if they don't know what they're walking into, then how can we expect it to work to the optimum?
I've got 2 questions for you, Tony, before we ask Steve to move on. Look, one's a cheap shot. Okay, cheap shot incoming, and then the other one is more serious. But the first one, with the retroscope in hand, would you still have the National Prescribing Centre in existence today?
So there have been suggestions for an over-prescribing network, such as they have in Canada, that's been very effective. And something like the National Prescribing Centre or the equivalent would be a great hub for that type of thing. So I think many people look back very fondly to the days of the National Prescribing Centre and are aware of the tremendous impact it had.
Yeah. tprescribing.co.uk if anybody wants to do anything with that. I'm the proud owner of many of those domains. We're just waiting for that rainy day.
Yeah, but none of us like deprescribing, which is why we've moved to overprescribing.
And then the next one was coming back to the behavioural conference that I attended earlier in the week in Liverpool, Tony, and how do we get behavioural scientists and health psychologists onto this agenda with us around clinician behaviour and patient behaviour?
Yeah, well, a great example of that is that we have a behavioural sciences unit within NHS England. I only found that out a couple of months ago.
The nudge
but they're
unit.
Great. Yeah, they are great, and so they're working with us at the moment in terms of working out what are the best messages to be sending, in terms of a particular thing that we're trying to develop at the moment and implement. So it can often seem very simple, the wording, as if you could make it up yourself, but it's got the science behind it and a lot of thinking, and they're very, very good at being able to work out what sort of message is going to work best in a particular circumstance. So I think that's one example, and they're working with us, they're working with other parts of NHS England very effectively, I think.
I think we'd all echo that.
The Aural Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
So, Tony, thanks very much so far. As you might know, being a guest on the Aural Apothecary comes with a few things. And the first one is we're after a desert island drug, which is a drug that evokes a very powerful memory for you to go into the Aural Apothecary formulary. So what would you like to offer us and why?
Okay, so I thought about this quite a bit, and I can't think of a drug that evokes powerful memories for me. But over the course of time, I'd say that atorvastatin stands out. So I was drawn to general practice partly because I wanted to focus on prevention rather than cure. But in the early days of my career, that was focused mainly on encouraging lifestyle change. And over time, it's been increasingly clear that in addition to lifestyle changes, medication can have a really important role in primary and secondary prevention, particularly in relation to cardiometabolic disease. And I think the introduction of statins in the late 80s and increasing evidence of their benefits means that alongside those other interventions in primary care, we can prevent significant numbers of heart attacks and strokes. And that's a real motivation for me in my work. And as you know, simvastatin was the first choice statin initially in primary care in the UK, but since atorvastatin came off patent in 2012, it's been great to be able to use this as it has a better side effect profile and fewer interactions.
Well, let me tell you, you're incredibly good company, and I don't know if you've been speaking to him, but another of your professors who's recently retired from NHS England also picked atorvastatin. And do you know who that was? It was
No?
Professor Alf Collins.
Oh, Alf! Yeah, I've listened to Alf.
So he picked it, and it was also picked by Dr. Mahindra Patel, who's a pharmacist who's also interested in the gap in relation to, he talked about the Bradford donut, and the people who need it most are not getting it, and the people who are on the outside, on the periphery, the wealthy and the better health people have got access to it. So you're not alone in picking statins, that's for sure.
It's an interesting one, atorvastatin, because there would be some people who say that falls in the category of something that's overprescribed, or statins in general as well. And so I know, so it sits on both sides of what you're interested in.
It's an interesting one. I mean, obviously you've got the secondary prevention side of things, where provided the patient wants to take statins or prepared to take them, then I think there's very strong evidence of the benefits. I mean, all the medicines I prescribe for primary prevention, it's the one where I have greatest discussions. We don't tend to get into deep discussions with patients about whether they take an antihypertensive, even though their blood pressure may not be that highly raised. They may be no more putting them at risk than their cholesterol being a bit high. So I think it's one of those medicines where, particularly on the primary prevention side, we have a lot of discussion. In fact, I just find it fascinating that as a result of those discussions, many patients decide they don't want to take them, even when, to me, I think it sounds like they've got a fairly high risk. They've got 20% or more risk, but they may say, I'm not really a tablet taker, doctor. And so it's their choice. We'll leave it. We can come back to it perhaps in a few years' time. And I guess when you're thinking of deprescribing in later life, then it's obviously one that you can be considering. But if it's patients still feel that they want, they're still reasonably healthy, and they're still looking at, how long can I live, and I know people's priorities change. There are other things that you might go to first, let's say, that may be causing them more problems. But I certainly accept that when you're getting people who are very frail and closer to end of life, then you then get into the area where it's those medicines are likely to be futile and not really likely to be bringing any further benefit.
Okay, so definitely another vote for statins in the Aural Apothecary, and it's probably that class of medicine that's got more clinical trials than any others on the planet, I would think. Okay, what the second thing we're after is something for the Aural Apothecary Spotify playlist, and I know you've got something special lined up for us. So, but would you like to give us, to begin with, what you've picked and why?
Well, but Tony, before you do that, let's give the listener a little taster, and then we'll come back to Tony.
Okay.
Here's a little taster. There we go, Tony. Talk us through that.
Okay, it's Father and Son by Cat Stevens. So I've been playing guitar and singing since I was aged 8, and in my teens I played Cat Stevens alongside many other artists. And Father and Son is still my go-to song. I still get a great feeling when I play it. As most of your listeners will know, it's a song in 2 parts, the father advising the son to settle down and the son hitting back with wanting to break away. And I'm not sure how much it relates to my own situation, but it certainly brings up powerful emotions when I play it.
That's a fabulous song.
Well, shall we hear Tony now? We can hear.
I think we should. Yeah, You cut it off in its prime.
No, that was the taster.
Okay.
I told you it was an Aural Apothecary first, and he's raised the bar for future guests to come on, because now you have to bring a professional recording of yourself on. Take a listen to this.
How can I try to explain? When I do, he turns away again. It's always been the same old story. From the moment I could talk, I was ordered to listen. Now there's a way, and I know that I'll have to go away. I know I'll have to go.
Very good.
Wow,
Impressive.
That's fantastic.
Yeah.
Good.
You've definitely raised the bar there, Tony.
Yeah, thank you very much. Well, that was a treat from my son for a significant birthday a couple of years ago, that a recording studio experience. So, for anyone who does play or sing, it's a great thing to do. Great thing to do.
Yeah.
I think we've got our first booking for Medstock.
Yeah. Maybe we
absolutely.
should have a professional recording experience for the podcast.
Yeah, imagine that, a professional recording experience.
Okay, so Father and Son by Cat Stevens will definitely be in the
I
Aural
love that
Apothecary Spotify playlist. It'll make that playlist even richer than it already is. Okay, and the third thing, Tony, is a book for the Aural Apothecary Library, something that you think that is important to you, or you might want to get the message across to listeners.
So it's contemporary. It's Demon Copperhead by Barbara Kingsolver. Barbara Kingsolver is an incredible writer, and this novel is a modern take on Charles Dickens' David Copperfield. And the reason why it's relevant to this podcast is because it gives a very powerful account of how people from disadvantaged backgrounds can find themselves starting opioids and then end up getting stuck on them with subsequent devastating effects for them and the people around them. So it's not exactly a laugh a minute, but I was captivated by the writing, and there is a hint of a positive outcome at the end.
Anybody read that?
No, but
it's here somewhere. It's on my to read pile.
and it obviously fits in with Sir Michael Marmot's pitches at conferences and all his work and his books. Somebody again asked him at the conference this week would he run for politics. But he declined. But yeah,
Yeah, it sounds. I can understand the link there, Tony. So that's Demon Copperhead. Demon Copperhead.
Yeah.
By Barbara Kingsolver.
Yeah.
Is that right?
Yeah. Yep.
Okay. Excellent. Really enjoyed those 3 choices.
very good. Our micro discussion next, and informed, because it's about 270 pages, looking at the Chief Medical Officer's annual report for 2023 in England, Health in an Ageing Society. What's your starter for 10, Tony?
Well, I think it was great to see that coming out on the focus on older people. I think one of the great things about it was just recognising, as Chris Whitty said in his foreword, that many or most people do live in good health in older age. The vast majority of people don't have dementia, and therefore, and that's certainly my experience as a GP of having older people coming in who are living, fulfilled lives, and we're just trying to help them along with some of the conditions that they have. So just recognizing the importance of primary and secondary prevention to delay disease, to maximize opportunities for healthy old age, and the importance of managing multiple morbidity and having clinicians who are comfortable with doing that, but also recognizing the focus for many older people on their quality of life rather than longevity. And although the report doesn't say a lot about medicines. It's quite clear that there's an important focus there for judicious use of medicines in older people and managing polypharmacy.
That struck home for me when he talked about that. He explained it quite nicely about how that then sort of increases that gap that you've got in your old age of a good quality of life. It got me thinking, because in the news, I think it was this week or last week, was the number of people in the country with diabetes, and it's just shot up again, and it's perhaps no surprise, but it's something like I'm sure it's 1 million people living with diabetes who don't know it. So I think it just echoes his point, doesn't it, that there's so much to do on the prevention of chronic disease, but a focus on that window that we're all getting closer to of a quality of life in our old age is really important.
I thought there's a fascinating thing as well, just in relation to when you get into your 90s, if we ever get into our 90s. But that actually at that stage has been, once people are in their 90s, there's been very little change in terms of life expectancy once you get to that age. And so suggesting there really is, at the moment, a sort of limit to your sort of natural lifespan. And I suppose it goes back to the point about what we're doing with our medicines in that age group, and to be focusing on those medicines that are helping people with their symptoms and helping with quality of life.
Well, I think he specifically says that, doesn't he? Don't focus on longevity, focus on the quality of life. And I just thought it was really nice the way he put it.
Yeah, so it's lifespan versus health span, isn't it? So this
Yes,
idea that
it.
you can live well even till the day you die, as opposed to having 10 years where you've just got all this morbidity and all these things that you've got to deal with. And really, you remember in the last episode me saying about, and it's very clear in this document, that's where the graphs come from, where they've been there before, about it's worse with more deprivation. So we've got lots of deprivation, you get more morbidity earlier, and therefore their health span is less. And the other bits I like about it is that, and as you say, there's not a huge link across to polypharmacy, but obviously it's in there, and there is a mention about pharmacists and their role in risk of polypharmacy. But I guess it's a good springboard for you, Tony, isn't it, in relation to your role in trying to use this, as because he's essentially saying we need to connect these two together. And there's two things that I liked in particular, and I'm going to read them out like Jamie does. So the first one is this, and it says, some treatments may extend life, but at the expense of reducing its remaining quality and independence. The decision about how to balance these should be the patient's. This needs full and realistic information from their medical advisors. And that's a bit like the conversation we were having earlier about when I got on my soapbox about diuretics and people with heart failure, because it is their decision and about whether they want to what their quality of life is versus their quantity of life. And the other thing it says, isn't it, is that, and I live in one of these areas, but it's very clear, isn't it, when you look at the geography, that people move out of cities before they get old, and it's the coastal and semi-rural peripheral areas that are the ones who are receiving all these older people, and will have, by 2043, it's saying up to 25% of people will be over the age of 75, and those areas have got to get up to speed in being able to help to deal with these patients who have got all this, who are just older but have got multimorbidity, and we're not ready for it, are we?
There was a line in there, Steve, that I thought you would have read out. Much of the medical profession is organised around single diseases and single organ systems. And then he goes on to call for more generalists. So I did think of you when I read that.
Yeah, that was going to be my next thing. So thanks for bringing that, because I'm going to read that.
I highlighted that as well, and I just put Chris
Steve
listens to the podcast. Clearly.
Well, maybe he does, because he talks about polypharmacy and multimorbidity. He essentially talks about the inverse care law a lot. And he talks about singing organologists, so I definitely think he's a fan.
And I think the bit that Tony highlighted at the start from the foreword, I just wrote Lucy Pollock on the paragraph, which is again is Lucy's mantra of aging well, and that this isn't all gloom and doom, and that her patients, that's the stories she shared with us, wasn't it?
Yeah, and that point is rather than are you good enough for the drug? Is the drug good enough for you? Is this drug now at this time in your life actually good enough for you? Is it helping you enough that it's worth having, or is it causing more harm than good?
One thing I liked about it is it had a chapter dedicated to falls as well, and I'm on a bit of a crusade about falls. And I think when you're in that sort of the sort of quality of life zone, there's often like a tipping point that tips you into that sort of end zone, and falls is often it. And so I think I was really pleased to see that, because he talks about frailty not being the same as multimorbidity, and I think so there are a couple of keystone issues like falls that we could look at to make a real difference here.
Yeah, and when you've got someone with falls, that might be because they're being too tightly controlled with their blood pressure, then it's almost certainly the case that loosening off on the antihypertensives is going to be the best thing for the patient.
Yeah,
courage and confidence.
I did click on the chapter just to see how he described realistic medicine and the work from Scotland. And of course, we've got Catherine Labinjo coming on the podcast later in the series, a cardiologist and one of, I think, realistic medicine lead probably in Scotland as well. So we will
she's the medical director of that, yeah?
We will be able to pick that up with her in a later episode. What are your views on realistic medicine and prudent prescribing and all these choosing wisely, Tony?
Well, I think it just fits very much with my approach and philosophy, really.
Okay, thanks Tony for joining us on the Aural Apothecary and for sharing his stories, his desert island drug, playing his career anthem, no pressure for future guests, and his book for the Aural Apothecary Library. Coming up next time, we'll be joined by Alison Tennant. Alison is the Chief Pharmacist at Birmingham Women's and Children's NHS Trust. She's currently Chair of the Chief Paediatric Pharmacist Group and the Clinical Reference Group for the Children's Hospital Alliance. Join us next time on the Aural Apothecary. You can contact us via Twitter at Aural Apothecary. We're on LinkedIn. You could email us, auralapothecarypod@gmail.com. Don't forget the website, theauralapothecary.com. Gimmo now with a final ingredient.
Okay, so thank you, Tony. That was fantastic. And as you know, we're all sort of huge fans of what you do and appreciate the fact that you work with Steve on a regular basis and how tough that must be. Okay, so last week we talked about naloxone and the importance of getting it administered as quickly as possible. So for those who don't remember, naloxone is an antidote to opioid poisoning, so it's used when drug users have taken an overdose, and it's a lifesaver. So how can we ensure that we get naloxone to the site of an overdose as quickly as possible? Well, one answer that's being explored is the use of drones. So I think we've talked about drones on the podcast before, and there are examples of them being used to deliver medicines. For example, in remote corners of Scotland, where logistics make it very difficult to get things like cancer drugs to isolated communities. But this is something different, where the drone is part of an emergency response. So in October last year, a study in the journal Addiction hypothesised that drones could have reached 78% of fatal overdoses within 7 minutes of the emergency services being alerted. So that's a huge increase in the 14% that are currently reached, and that would be a lot of lives saved. This was based on modelling, but recently in the US, a study has shown how an onlooker, even one without prior training, could successfully administer naloxone to an overdose victim when the drug is delivered by a drone that is also carrying a video screen that shows instructions how to administer the drug via nasal spray. So the trial actually showed the average time for someone to remove the naloxone from the drone, view the video and administer the medicine was 62 seconds. So one of the things stopping this happening at the moment is the current rules around drones, but the Civil Aviation Authority has announced plans to change those rules and make it legal to fly things like medicines without line of sight to the pilot. So there you have it. There's another example of technology coming to the rescue in a way that we might not have anticipated. It's a real potential lifesaver for hundreds, if not thousands, of overdose victims.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Aural Apothecary podcast. It's all about pills, thrills and bellyaches.
This episode of the Aural Apothecary is sponsored by jamiehayes.co.uk.